Hello everyone. Today we will be discussing about disclosing agents. We will be seeing disclosing agents, definition of plaque, ideal properties, composition, action, dyes used as disclosing agents, method of application, applied aspects, and conclusion. So guys, the definition of dental plaque. By according to WHO 1978, dental plaque is defined as a specific but highly variable structure resulting from sequential colonization and growth of micro on the surface of teeth and restoration. Consisting of micro of various strains, species are embedded in the extracellular composed of bacterial metabolic products and substance from saliva and blood. Brightshaw and Marsh in 1999 defined it as dental plaque is a microbial film, a diverse microbial community found on the tooth surface embedded in a matrix of polymers of bacterial and salivary origin. Now, identification of dental plaque. Elimination of bacterial plaque from the tooth surface is essential for maintaining dental health. It is often difficult, however, to convince patients about the importance of performing thorough oral hygiene. Patient motivation, therefore, represents an important aspect in improving oral hygiene. Now, definition of disclosing agent. According to Rabin in 1943, a disclosing agent is a solution which, when applied on the tooth, makes visible by staining, roughness, and foreign matters on the tooth. According to World English Dictionary, a disclosing agent is a dye in a liquid or tablet form that colors something, especially the teeth, to show. The history of disclosing agent. Skinner in 1914 first disclosing solution. Patients' teeth were disclosed with this solution to demonstrate soft accumulation, which had to be removed by patient at home. Then Berwick in 1920 used combination of brilliant green crystal violet. Then Eslick in 1935 demonstrated Bismarck brown. Then in Raven in 1943 gave gentian violet. Now, utility of disclosing agents. Diagnosing the dental plaque, personalized patient instruction and motivation, self-evaluation by the patients to evaluate the effectiveness of oral hygiene maintenance, and preparation of plaque indices. Ideal properties of disclosing agent should be taste. It should have patient. It should be according to patient comfort, and also non-flavored. Should encourage patient cooperation. Intensity of color. It should be evident contrast to differentiate from surrounding environment, and duration of intensity. Retentive. The color should not rinse off with ordinary rinsing method for the period time required to complete the instruction or clinician examination. It should be non-irritating to oral mucosa. It should be non-allergic and non-antiseptic property, and it should have an antiseptic property. So these are the various stains which are used in disclosing agents, that is red, blue, green, yellow, and Hercules yellow color. Now, mechanism of action. Disclosing agents work by changing the color of dental plaque so that it contrasts with the white tooth surface. Dental plaque has the ability to retain a large number of dye substances which can be used for disclosing purpose. This property is related to interaction because of the polarity of difference between the component of plaque and dyes. The particles are bound to the surface by electrostatic interaction and hydrogen bonds. Now the dyes used as disclosing agents are iodine preparation, mercurochrome preparation, and Bismarck brown. Then merbromine, erythrocin, fast green. Seventh is fluorosin, two-tone solution, basic fustian, and three-tone gel. Iodine preparation, that is Skinner's iodine solution. In that, iodine crystals are used and potassium iodide is used along with zinc iodide and distilled water. And in diluted tincture of iodine 21% and 15% distilled water is used. Iodine based solution. Plaque colors as deeply dark brown or black. Inflamed gingiva is as dark areas. Discoloration disappears in a few minutes. Advantage is it is low cost and good for clinical photographs. And the disadvantages are patients is allergic to iodine. Some patients are allergic to iodine and objectionable tests. Then mercurochrome preparation. Mercurochrome solution consists of mercurochrome 1.5% and distilled water 30%, and flavor mercurochrome with distilled water and oil of peppermint is used. Bismarck brown. Bismarck brown is, 3 gram is used along with ethyl alcohol, glycerin and anise, that is a flavor. Merbromine. Merbromine is 450 milligram along with oil of peppermint and distilled water is mixed. Erythrocin. It is based on purpose by rinsing for direct topical application and tablet or wafers. By rinsing, uh, alcohol along with distilled water and peppermint oil is used. For direct topical application, erythrocin 0.8 gram with alcohol, distilled water and peppermint oil is used. Tablets or wafers are sodium chloride, sodium sucryl, calcium stearate, white oil and flavoring agents is used. However, with regular use of FDC red number 3 tablets, it becomes abundantly clear that the pleasing shade of red adversely affects the utility of wafer. The plaque interproximally and at the gingival margin, especially in the posterior areas, could not easily be seen because of poor contrast between the gingiva and the stained plaque. According to the use of red disclosing dye reveals that red is the wrong color, since plaque that has been stained red is extremely difficult to see due to the poor contrast with the oral tissue, especially in the black area of the mouth and between the teeth. It should be noted that it is this precise area which are the most prevalent site of caries and periodontal disease. Advantage of erythrocin dye. It does not stain dental equipment or clothing permanently, does not stain composite type restorative permanently, does not have any known possible effect that iodine or mercury stain possess. Then next stain is fast green and fluorescent. Fluorescent is FDC yellow number 8 used with special ultraviolet light source to make the agent visible. Uh, Two-tone solutions, that is FDC green number 3 and red number 3. These are thicker plaque stains blue and thinner newer plaque stains red. The central blue staining mask would show a bacterial population and degree of organization that would be typical of old plaque, while the red peripheral zone would show the characteristic of newly formed plaque. The red staining may have been due to the uptake of dye by the structuralist cuticles or mucoprotein layer which forms on the enamel surface of the prior to the plaque formation. So onto the in the second image we see that the central mass is quietly reddish in color, which is a newly formed plaque, and in the cervical region and in the inner dental region the dark blue staining is seen, which is the older plaque. Blue plaque clinical and red plaque. Uh, Blue plaque is considerable greater thickness than the red plaque. Red is extreme thinness to the extent that sometimes it is hard to obtain sufficient material for examination. High degree of architectural organization, that is cocci, low density of organisms in red plaque. Rods and filaments are arranged in parallel row, forming fan-shaped patterns. Filaments and intertwine form a mesh work. There is no evidence of any orderly architecture. Motility present in some blue plaques, and no motility is seen in red plaque. Spiral organisms and vibrios are present. No filament spiral organisms or vibrios are present in red plaque. Now basic fustian. In this 6 gram of basic fustian is used along with ethyl alcohol, used by adding 2 drops of distilled water in a dampened. Methods of application. Solution for direct application. Retracting the cheek and tongue, air drying the teeth, carrying the solution in cotton pellet or swab and applying it on the crown of the teeth. The patient is directed to spread the solution overall surface of the teeth. The distribution is examined and patient is instructed to rinse. Then rinsing. Few drops of concentration preparation. Water is added to dilution. Swish and rinse for 1 minute, examining all tooth surface. Tablets for wafers. After chewing, tablets or wafers are to be switched for around 30 to 60 seconds and then rinse. Now the effects. Clean the tooth surface. Do not absorb the coloring agents. The pellicle and bacterial plaque, if present, absorbs the agents and thus disclose. Pellicle stains relatively thin clear covering, and bacterial plaque darker, thicker, and more opaque. Now the applied aspects. GC plaque indicator kit. Now out of assortment is replaced by GC tri plaque ID. Now GC tri plaque ID gel. These are unique three-tone plaque disclosing gels that identifies new mature and acid producing biofilms. Difference among fresh plaque, mature plaque, and strong acid producing plaque by color to aid in patient oral hygiene education. Uh, the light pink color plaque is the newly formed plaque, and the dark blue color plaque is the plaque which is formed uh, beyond 48 hours, and the light blue plaque is the acid producing plaque. Now the ingredients are glycerol, sucrose, ethyl alcohol, and sodium carboyl methyl. Direction for use. Apply GC tri-plaque ID gel onto the tooth surface using a suitable instrument, that is microbrush, swab, or toothbrush. Dispense gel into a dish if applying on multiple tooth surface. Following this, the patient is instructed to lightly rinse their mouth with water. Plaque identification by observing the color of the gel. A pink or red color is a fresh plaque accumulation. A blue or purple color is after 48 hours. A light blue color is mature and strong acid producing plaque. Patient is instructed about proper tooth cleaning and thereby remove any remaining plaque and disclosing gel. Contraindication: patient sensitive or allergic to benzoate preservatives are contra. Now, in conclusion, this study shows that a total removal of root deposits during an osseous resective surgery is never obtained with conventional instruments. Clinical limitations and visual deficiency could be primarily responsible for the present results. In order to overcome these obstacles, the use of plaque disclosing agents during resective surgery seems to be effective. Through this observation, the post-operative clinical parameters remains to be assessed in order to evaluate attainable advantages that affects both recovery phase and long-term periodontal health. Such observation would constitute an interesting starting point for future experimental studies on this subject. These are the references. Thank you.